All right, everyone, welcome back. Tonight, we're diving into patient assessment. This is where it all starts to come together, folks. Module 1 was just the appetizer. Get ready because we're digging into the main course now. Welcome to Module 2 of the ARES EMT program. Now, I want you to really soak this in. Success as an EMT isn't about being a medical genius. It's about being a technician. You're not diagnosing conditions or designing treatment plans. That's for doctors. Your job is to master the systematic approach to patient care. That's why tonight's focus is so important. All right, everyone, tonight we're kicking off with an overview of the big picture goals for this section. By the end of this lesson and the next, you should feel confident applying key assessment skills to guide your decisions in the field. Let's break it down. First, we're covering scene size up. This is all about understanding your environment. You'll learn how to assess scene safety, manage hazards, and decide when you need additional resources. It's the foundation of staying safe and effective in any emergency. We'll also look at how environmental factors like weather or violence can change your approach to patient care. From there, we'll dive into the primary assessment. This is where you identify life-threatening conditions. You'll learn how to evaluate consciousness, check the ABCs, airway, breathing, circulation, and start critical interventions to save lives. Your ability to stay calm and focus on these basics makes all the difference in those first few minutes. Now, keep in mind this is just the start of your assessment skills. Tonight, we'll focus specifically on scene size up and primary assessment, getting you comfortable with those steps. In the next lecture, we'll dive into secondary assessment, patient history, and how to reassess as situations evolve. So, here's the takeaway. By the end of tonight, you'll know how to assess a scene and stabilize a critical patient. Sound good? Let's get started. The importance of patient assessment can't be overstated. It's the backbone of everything we do in EMS. Every decision you make begins with how you assess the scene and the patient. Without a solid assessment, the care plan falls apart. The assessment process is divided into 4 main parts. First, there's scene size up. This is where you evaluate safety and gather the big picture info. Then we move to the primary assessment, where you focus on identifying and addressing life-threatening conditions. From there, we go into secondary assessment, which includes the vital signs and history, and finally, reassessment. These steps help us get the full story and adapt our care as things change. The order of these steps isn't always rigid. After your scene size up, you may need to adjust based on the patient's condition. For example, if someone's in cardiac arrest, fixing that takes a different order of steps than someone with a pulse. Now, let's clear up something important. Rarely will one sign or symptom tell you exactly what's wrong with the patient. Signs are objective things you can observe or measure, like blood pressure or a visible injury. Symptoms are subjective, what the patient feels and describes to you, like pain or nausea. Together, they help you piece together the puzzle. By the end of this lecture series, you'll know how to put these steps into action and adapt to any situation you face. Let's dive in. Scene size up is your first step in every call. It's your evaluation of the conditions you'll be working in, and it's critical for keeping yourself, your team, and your patient safe. It's not something you do once and forget. Situational awareness needs to be maintained throughout the entire call. Safety is a constant priority. When you're dispatched, you'll get basic information about the call. This might include the type of emergency, the location, or any known hazards. But don't stop there. Scene size up means combining that initial dispatch info with your own observations and understanding of the situation. This helps ensure your operations are both safe and effective. There are 3 key elements to consider. First, take care of number 1, BSI, like wearing gloves and PPE and making sure you're not going to become the next patient is always top priority. Second, do a quick triage of the scene and see what help you might need. This could be additional responders, higher levels of care, the fire department, police, power company, etc. And third, once you choose the patient you intend to work on, consider the mechanism of injury, nature of illness, and whether the patient may need spinal precautions while you work. More to come on this as we progress through the chapter. What you observe in real time is often the most reliable guide for what happens next. Scene size up sets the tone for everything else. If you do it right, you're setting yourself up for a safer and more effective call. Ensuring scene safety is priority number 1. The challenges you'll face in the pre-hospital setting can range from minor difficulties to major dangers. If a scene isn't safe for you or your team, don't rush in. Your first responsibility is to make it safe or call for the right resources to help manage the risks. Let's start with traffic safety. If you're approaching a patient on a busy roadway, think about oncoming cars. Use emergency vehicles to create a barrier, wear reflective gear, and stay alert. Beyond traffic, consider environmental conditions. Is it icy, raining, or scorching hot? Each of these can change how you approach care. Safety doesn't stop at you and your patient. Help protect bystanders too. Prevent them from wandering into dangerous areas. Remember, every hazard could turn a bystander into another patient. Now, let's talk hazards. They come in many forms. Environmental hazards like extreme weather, physical dangers like sharp metal or broken glass, and chemical risks like hazardous materials. Don't forget electrical hazards, water dangers, fire, or even the threat of explosions. And then there's physical violence. This could be from a violent patient, distraught family members, angry bystanders, gangs, or unruly crowds. Always stay vigilant. One key thing to keep in mind, emergency scenes are dynamic. What's safe 1 minute might change the next. Stay aware, keep scanning for new dangers, and adapt as the situation evolves. Just because it was safe when you got started doesn't mean the situation will always remain safe while you're working. If you don't feel safe, back off and reassess. You can't help anyone if you become a patient yourself. Once you've ensured the scene is safe, your next step is figuring out what brought you there in the first place. The mechanism of injury, or MOI, and the nature of illness, or NOI. These help you understand what's going on with your patient and guide your approach to care. Every call you respond to will fall into one of three categories: medical conditions, traumatic injuries, or a combination of both. Traumatic injuries happen when physical forces are applied to the body, like an object striking the patient or the patient striking an object. If the call involves trauma, your job is to determine the MOI. Pay attention to terms like blunt trauma, where the body is struck by a non-penetrating object, or penetrating trauma, where something like a knife or bullet breaks the skin and deeper tissues. For medical patients, focus on identifying the NOI, the underlying cause of their symptoms. Is it a cardiac event, a respiratory issue? The NOI will shape how you assess and treat the patient. One more thing, always be alert for scenes where multiple patients have similar signs or symptoms. This could point to something like carbon monoxide poisoning, foodborne illness, or even a hazardous material situation. Stay sharp and think about the bigger picture. Understanding the MOI or NOI gives you a starting point to dig deeper into what's happening with your patient. It's a critical step in delivering the right care. Understanding the mechanism of injury, or MOI, and the nature of illness, or NOI, is about more than just checking a box. It's about preparing yourself to take the right steps for your patient. Thinking about these factors early helps you anticipate potential injuries or illnesses, decide on treatment priorities, and plan your next moves. Let me stress something here. When you reach this step in your assessment, it's not enough to simply say you're assessing the MOI or NOI. You've got to verbalize what you actually think it is. Is the MOI a high-speed vehicle collision? Is the NOI a suspected stroke? Say it out loud. By doing that, you're forcing yourself to process the situation, justify your treatment priorities, and set a clear path for the interventions you'll perform. This habit is critical, not just in school but in the field. Unfortunately, this step is often overlooked by students and sometimes even by instructors during evaluations. Don't let it slide. Your ability to identify and articulate the MOI or NOI ties directly to your effectiveness as an EMS provider. Get in the habit of thinking through and verbalizing this step every single time. Remember, understanding the MOI or NOI isn't just about what's happening now. It's about setting yourself up to provide the best care moving forward. Before you ever approach a patient, taking standard precautions is non-negotiable. It's your first line of defense against exposure to blood, body fluids, or anything else that could put your health at risk. Gloves, at a minimum, are required before any patient contact, and depending on the situation, you might need additional PPE like glasses, masks, or even gowns. It's all about adapting to the specific risks of the call. Here's something crucial, especially for those of you preparing for the registry exam. Anytime a scenario question asks, "What's your first step?" the answer is always, without exception, BSI scene safety. It doesn't matter how the question is framed, what details they give you, where they place you in the scenario, or how many responders are already there. The correct answer is always about ensuring your own safety first. Every other option, no matter how urgent or logical it might seem, is just a distractor. This isn't just a test trick, it's an essential practice in the field. If you're not safe, you can't help your patient. So when you're studying or taking the exam, make BSI scene safety the reflex answer for those first step questions. It's your registry hack, but more importantly, it's how you stay ready to work safely and effectively in real-life situations. Another critical step in your scene size up is figuring out how many patients you're dealing with. It's not always as straightforward as it sounds. You need to take a moment to assess the entire scene and make sure you've accurately identified the total number of patients. Missing someone could mean a delay in care, and that's on us as responders. If you find yourself dealing with multiple patients, it's time to shift gears. Use the incident command system to maintain organization and control. First, identify the number of patients. Once you've got that number, move into triage. This is where you quickly sort patients based on the severity of their conditions so you can prioritize care and resources effectively. We'll go over Incident Command System, or ICS, at a basic level throughout the course during skill scenarios, but we highly recommend taking the ICS 100, ICS 200, and ICS 700 courses from the FEMA website when you get time. They're actually required by most response agencies anyway. Remember, in a chaotic scene, staying calm and methodical is key. By properly identifying the number of patients and organizing the response, you're setting the stage for a smooth and efficient operation. This step might seem simple, but getting it wrong can throw off the entire call. Sometimes the situation at a scene calls for more than just your team. A key part of scene size up is recognizing when you need additional or specialized resources. This isn't about doing everything yourself. It's about knowing when to bring in the right help. Specialized resources can include advanced life support, or ALS, for patients needing higher-level care. Air medical support may be necessary for rapid transport or in hard-to-reach areas. Fire departments often handle things like hazardous materials, technical rescues, complex extrications, wilderness search and rescue, or high-angle and water rescues. And of course, law enforcement is essential for scenes involving violence, crowd control, or criminal activity. When you're assessing the need for additional resources, ask yourself these 3 questions. First, does the scene pose a threat to you, your patient, or anyone else? Second, how many patients are there? If it's more than you can handle, you'll need backup. Third, do you have the resources to effectively respond to their conditions? If not, it's time to call in reinforcements. Remember, knowing your limits isn't a weakness. It's smart, safe, and professional. Calling for the right help at the right time makes all the difference in delivering effective care. Patient assessment starts the moment you meet your patient. From that very first interaction, you're gathering information, how they look, how they respond, and even their body position can give you clues. This is where the primary assessment begins. The goal of the primary assessment is simple. Find and begin treating any immediate life threats. You're focused on the big issues, the ones that need your attention right now to keep the patient alive. To do this, you'll physically examine the patient and assess their level of consciousness, or LOC, as well as their airway, breathing, and circulation, the ABCs. These steps must always come first and must be done in order. It's the foundation of everything else you'll do for the patient. Now, here's a registry hack you'll thank me for later. The primary assessment is the only part of the entire assessment process that must always be completed in a specific order. When the registry asks scenario questions like, "What is your next step?" the best way to get the right answer is to figure out where you are in the primary assessment sequence. If the scenario says you just checked the airway, the next step will be assessing breathing. If you just stabilize breathing, you'll be moving to circulation. The trick is recognizing that while all the answers might look correct, only one of them fits the proper sequence of the primary assessment. This method helps you cut through the confusion when everything seems right. Stick to the order, and you'll always land on the correct next step. Mastering this sequence isn't just about passing the test, it's about saving lives in the field too. The primary assessment keeps you focused on what matters most. The first step in your primary assessment is forming a general impression. This is your initial snapshot of the patient, and it helps you determine the priority of care. Think of it as the gut check, the moment where you ask yourself, is this patient sick or not sick? Your answer will guide everything you do next. Start by noting key details: the patient's age, sex, race, level of distress, and overall appearance. These may seem like simple observations, but together they give you a baseline to work from. As you approach, make sure the patient sees you coming. Observe their position. Are they moving or still? These clues can tell you a lot about their condition before you even say a word. When you interact with the patient, keep things calm and professional. Avoid towering over them if you can. It's less intimidating. Address them by name, introduce yourself, and ask about their chief complaint. How they respond, or if they respond at all, can give you valuable insight into their level of consciousness, airway patency, breathing, and circulation. Remember, if you see a life-threatening issue, stop and address it immediately. Time is critical for things like airway obstruction or severe bleeding. As you continue, decide if the patient is stable but potentially unstable, or unstable. This is your opinion as an EMT, and it directly influences your next steps. At the end of the day, forming a solid general impression is all about answering that simple question: sick or not sick? Your instincts, supported by what you observe, will point you in the right direction. Next up in the primary assessment is assessing your patient's level of consciousness, or LOC. This step provides critical insight into both their neurological and physiological status. It can tell you a lot about what's going on under the surface. For unconscious patients, your focus immediately shifts to the ABCs: airway, breathing, and circulation. Unconsciousness is a major red flag, often signaling a critical issue with their respiratory system, circulatory system, or central nervous system. It's your job to intervene quickly and stabilize these life-threatening conditions. We'll touch on this more in a second, but if a patient is unconscious, your immediate next step should be to check a pulse. This will tell you whether you need to do medical assessments and treatments following ABC priorities, or if you should begin CPR, which follows a CAB priority. For patients with an altered LOC, think about potential causes. It could be poor perfusion, meaning their blood isn't circulating effectively. Other causes include medications, drugs, alcohol, or poisoning. Identifying the root of the problem helps you decide on the right interventions. Let's take a closer look at how we assess responsiveness using the AVPU scale. This simple but effective tool helps us quickly evaluate a patient's level of consciousness. If the patient is fully awake and alert, they're classified as A. If they respond to verbal cues, such as speaking or opening their eyes when you call their name, they're rated as V. If they only respond to painful stimuli, such as a sternal rub or a pinch, they're rated as P. And if they show no response to verbal or painful stimuli, they're classified as U unresponsive. If the patient is awake, the next step is to test their orientation by checking their memory. Ask questions to determine if they know their name, person, where they are, place, the current date, time, and what happened to them, event. If they miss any of these or show any deviation from their normal baseline, this indicates an altered mental status, which is critical to note as part of your assessment. If the patient is completely unresponsive to you verbally as well as to painful stimuli, immediately check a pulse at the carotid artery for no more than 10 seconds. If you feel a pulse in an adult, we'll talk about children toward the end of the course. Follow the ABC sequence of airway, breathing, and circulation. If you don't feel a pulse in 10 seconds, however, begin CPR using the CAB sequence, which is compressions first, followed by airway and breathing. Assessing level of consciousness, LOC, isn't just about collecting information. It's about understanding what's happening neurologically and physiologically so you can guide your next steps in care. LOC changes can provide vital clues about underlying conditions such as hypoxia, hypoglycemia, or head trauma. By using tools like AVPU and testing orientation, you're not only identifying the patient's current state, but also building a foundation for effective, focused interventions. After assessing your patient's level of consciousness, the next step is identifying and treating life threats. These are the conditions that can cause sudden death if they're not addressed immediately. Your primary job in this phase is to spot these threats quickly and act even faster to manage them. Remember, time and speed are your biggest priorities in the primary assessment part of your assessment. For example, you'll learn a bunch of different ways to secure an airway as an EMT, and each has their purpose. But in this early stage of the assessment, you should pick based on speed, even if it's not the most efficient. The conditions that can lead to sudden death include airway obstruction, respiratory failure or arrest, shock, severe bleeding, and primary cardiac arrest. In most situations, you'll handle these issues in the order of airway, breathing, and circulation, the ABCs. Start with the airway. Is it open and clear? If not, you need to fix it immediately. Then move to breathing. Is the patient breathing adequately? If not, or if they've stopped breathing altogether, you'll need to provide ventilatory assistance. Finally, assess circulation. Are they showing signs of shock? Your job is to prioritize interventions that address what's keeping, or could stop keeping, the patient alive. There are exceptions to the ABC order. For example, in cases of cardiac arrest, it's often more appropriate to reverse the sequence to circulation, airway, and breathing, CAB. If a patient is pulseless and unresponsive, chest compressions come first to restore circulation, followed by securing the airway and providing ventilations. Always remember, identifying and treating life threats isn't just about following a checklist. It's about recognizing what's killing your patient right now and intervening in a way that makes the biggest impact. Your ability to act decisively in this phase can mean the difference between life and death. The next critical step in your primary assessment is evaluating the patient's airway. Without a clear and open airway, nothing else matters. It's the foundation of life support. As you move through the assessment, stay alert for any signs of airway obstruction and make sure the airway is both open or patent and functioning adequately. For responsive patients, you can often tell right away if their airway is clear. If they're talking or crying, regardless of age, the airway is open. But if a conscious patient can't speak or cry, you're likely dealing with a severe obstruction. In this case, stop everything and focus on clearing the airway immediately. If they're struggling to breathe or not breathing at all, take corrective actions right away, whether that's repositioning, suctioning, or providing ventilation. With unresponsive patients, airway assessment takes a more hands-on approach. Start by checking the patency of the airway. If there's potential trauma, use the jaw thrust maneuver to open it without moving the cervical spine. But if trauma isn't a concern or the jaw thrust doesn't work, switch to the head tilt chin lift maneuver to open and maintain the airway. Be vigilant for signs of obstruction, especially in unconscious patients. Red flags include obvious trauma, blood, or other physical blockages in the airway. Noisy breathing sounds like snoring, gurgling, or stridor, or extremely shallow or absent breathing. Any of these require immediate action. Clearing and maintaining a patent airway is one of the most vital skills in EMS. Without it, nothing else you do can be effective. Always stay focused and act quickly when airway issues arise. Once you've ensured that the patient's airway is open, the next step is assessing their breathing. This means more than just confirming that they're breathing. You need to determine if their breathing is adequate to sustain life. Ask yourself 3 critical questions. Is the patient breathing? Is their breathing adequate? Are they hypoxic, meaning they're not getting enough oxygen? If the patient isn't breathing or if their breathing is too slow or shallow, you'll need to perform positive pressure ventilations immediately. For patients who are breathing but remain hypoxic, administer oxygen with a goal of achieving an oxygen saturation of 94% to 99%. If you encounter new breathing problems after your initial assessment, reevaluate the airway and adjust your interventions as needed. Certain criteria indicate the need for positive pressure ventilations with an airway adjunct. These include respirations that exceed 28 breaths per minute, respirations fewer than 8 breaths per minute, or breathing that is too shallow to allow adequate air exchange. Shallow breathing can be identified by minimal chest movement, reduced tidal volume, or poor chest excursion. Pay close attention to how much effort the patient is using to breathe. Look for signs like retractions, use of accessory muscles, nasal flaring, or 2 to 3 word dyspnea, where the patient can only speak a couple of words at a time. Watch for physical clues like the tripod position, sniffing position, or visibly labored breathing. It's crucial to differentiate between respiratory distress and respiratory failure. Respiratory distress involves increased effort or rate of breathing, while respiratory failure occurs when the blood isn't getting enough oxygen or ventilation isn't meeting the body's needs. If left untreated, respiratory failure will progress to respiratory arrest. Your ability to quickly assess and manage breathing issues is critical. Acting decisively in these moments can mean the difference between stabilizing your patient and watching their condition rapidly decline. Stay sharp and always be ready to adapt to the patient's needs. After checking airway and breathing, the next step in your primary assessment is evaluating the patient's circulation. This involves assessing 3 key factors: their mental status, pulse, and skin condition. Let's break it down. First, let's assess the pulse. Palpate the pulse to determine its quality. By this point, we should know if our patient has a pulse or not, but this is a good time to get some context. Is it weak and thready, bounding, missing from the radial artery but found in the carotid? These are signs that can point to shock, which is the biggest part of the C in the primary assessment. For responsive patients older than 1 year, check the radial pulse at the wrist. If the patient is unresponsive and older than 1 year, you'll need to check the carotid pulse in the neck. If the patient is somewhere between alert and unresponsive, such as responsive to verbal or painful stimulus only, check both the carotid and radial. Any pulse is good for proof of life, but if the radial is missing, your patient is going into shock and should be treated immediately. For children younger than 1 year, palpate the brachial pulse inside the upper arm. If you can't find a pulse in an unresponsive patient, or it's less than 60 beats per minute in a child or infant, it's time to begin CPR. Now let's talk about skin condition, which can reveal a lot about a patient's perfusion. Start by evaluating the skin color. Pale, white, ashen, or gray skin suggests poor peripheral circulation, often tied to shock or low blood flow. Flushed, red skin might indicate high blood pressure, fever, or another systemic issue. Blue skin, known as cyanosis, signals that the blood isn't properly saturated with oxygen, a serious warning sign of respiratory or circulatory compromise. Next, assess the skin temperature. Normal skin feels warm to the touch. Abnormal temperatures can indicate underlying issues. Hot skin may signal fever or infection, while cool or cold skin could point to poor circulation, shock, or hypothermia. Finally, evaluate the skin moisture. While dry skin is typical, wet, clammy skin might indicate shock or other circulatory issues, and dry, hot skin can suggest dehydration or heat-related illness. Don't forget to check capillary refill, especially in pediatric patients. Press on a nail bed or the skin of a finger or toe, then release. If the color doesn't return within 2 seconds, it could indicate poor perfusion, often a sign of shock or circulatory distress. Lastly, address external bleeding. Critical life-threatening bleeds take priority over airway or breathing concerns, so a tourniquet should have already been applied. Bleeding control at this step is considered a second pass. These are bleeds that might not kill your patient in the next few seconds, but will if they're not fixed in the next couple of minutes. Start with direct pressure. If that's not effective, or if there's an obvious arterial hemorrhage on an extremity, apply a tourniquet immediately. Rapidly controlling bleeding can mean the difference between life and death. Circulation is vital to your primary assessment. Always take a systematic approach to evaluating and addressing skin condition, capillary refill, and external bleeding to ensure you're covering all the critical factors. Once you've assessed airway, breathing, and circulation, the next step in your primary assessment is performing a rapid scan. This step is all about quickly identifying any life-threatening injuries or conditions that need to be managed or protected before transporting the patient. The rapid scan is exactly what it sounds like. It's fast and focused. Take no more than 60 to 90 seconds to complete it. This isn't the time for a detailed or systematic physical examination. You're not looking for every bruise, scratch, or minor injury. Instead, your focus is on finding major injuries or conditions that could rapidly deteriorate if left unaddressed, such as severe bleeding, obvious fractures, or impaled objects. This step is critical to ensure that no life-threatening condition is missed before you move on to further assessment or prepare the patient for transport. During a rapid scan, speed and attention to life threats are the priorities. It's not about perfection, it's about spotting the issues that need immediate intervention to give your patient the best chance of survival. Once you've completed your primary assessment, it's time to determine the priority of patient care and decide on transport. This step is all about recognizing the urgency of the situation and making the right call to get your patient the help they need as quickly as possible. High-priority patients are those with conditions that can rapidly worsen or are immediately life-threatening. These include unresponsiveness, difficulty breathing, uncontrolled bleeding, an altered level of consciousness, severe chest pain, pale or ashen skin, or other signs of poor perfusion, complicated childbirth, and severe pain in any area of the body. If you identify any of these conditions, the next steps become clear. Rapid transport is essential. Now let's talk about the golden hour, sometimes called the golden period. This is the critical window from the time of injury to receiving definitive care. Treating traumatic injuries and addressing shock within this period dramatically improves the patient's chances of survival. For many patients, immediate transport is the key to success, because it gets them to the advanced care we can't provide on scene. At this point, you must make your transport decision, consider the patient's condition, the availability of advanced care, the distance to the nearest appropriate facility, and your local protocols. For high-priority patients, this often means moving quickly to ensure they receive treatment within that vital golden hour. Making the right transport decision isn't just about following a checklist, it's about acting decisively while taking all factors into account. This is where your training, judgment, and experience come together to give your patient the best possible chance of survival. All right, team, let's wrap up this chapter on scene size up and primary assessment. We've covered some of the most critical foundational skills for any EMS provider, and you're making great progress. Well done. In this chapter, we focused on the importance of safety, awareness, and rapid decision-making. We explored how to size up a scene, assess for life-threatening conditions, and follow the steps of the primary assessment, including managing airway, breathing, circulation, and life threats. These are essential tools that you'll use on every single call, and they'll become second nature with practice. Next up, we'll dive into the secondary assessment, which builds on the skills we've covered here. We'll go deeper into how to gather a detailed patient history, perform a systematic physical exam, and reassess as conditions evolve. While it's a new focus, everything ties back to the same chapter in your book, so keep it handy as we move forward. Remember, this lecture and the next one each have their own tests, so stay on top of them and make sure you're solidifying what you've learned. Great work today. You're building a strong foundation that'll serve you well in this program and in the field. Keep up the momentum, and I'll see you in the next lecture.